This is a chest radiograph of a young man presenting with sudden, severe chest pain. The frontal radiograph shows a rim of lucency adjacent to the left heart border and increased lucency outlining the aortic arch and right paratracheal region. On the lateral projection, the anterior wall of the trachea is clearly delineated and there is gas seen anterior to the ascending aorta. These findings indicate the presence of free air within the mediastinum. The CT confirms the presence of mediastinal gas without associated fluid or evidence of tracheal rupture, consistent with a spontaneous pneumomediastinum. The differential diagnosis for lucency along the left heart border includes pneumomediastinum, left pneumothorax, and pneumopericardium. However, the presence of gas tracking above the aortic arch and into the right paratracheal region, as well as subcutaneous emphysema, are characteristic of pneumomediastinum rather than pneumopericardium, which is confined to the pericardial sac and does not extend superiorly beyond the great vessels. Pneumomediastinum occurs when air escapes from the alveoli or airways into the mediastinum. This can follow a sudden increase in intrathoracic pressure from activities such as Valsalva maneuver, coughing, vomiting, or barotrauma from mechanical ventilation. The mechanism is known as the Macklin effect, where alveolar rupture allows air to dissect along bronchovascular sheaths toward the mediastinum. Less commonly, it may occur secondary to perforation of a hollow viscus such as the trachea, pharynx, or esophagus, or extension from a retroperitoneal or bowel perforation. Several named signs are described in pneumomediastinum. The continuous diaphragm sign occurs when the entire diaphragm is visualized continuously across the midline on the frontal projection due to air interposed between the heart and diaphragm. The ring around the artery sign refers to gas outlining the extrapericardial pulmonary artery on a lateral view. The V sign of Nacclerio is seen when gas outlining the descending aorta intersects with gas above the left hemodiaphragm behind the heart. Occasionally, air may dissect between the fascial planes of the pectoralis major, producing the so-called ginkgo leaf sign. It is important to note that pneumomediastinum does not change with patient position on decubitus imaging, unlike pneumothorax or pneumopericardium, where the air moves to the non-dependent side. Pneumomediastinum can coexist with a pneumothorax, but a pneumothorax itself does not cause pneumomediastinum. Management primarily involves excluding serious underlying causes such as tracheal, pharyngeal, or esophageal rupture, typically by performing endoscopy or a contrast swallow study. Once life-threatening causes are excluded, spontaneous pneumomediastinum is treated conservatively and usually resolves spontaneously within a few days without specific intervention. In summary, these findings are characteristic of a spontaneous pneumomediastinum, a benign but important diagnosis that should prompt exclusion of visceral perforation.